intensivist at Baptist downtown in the medical ICU. We are lucky enough to collaborate with him on quite a few patients in the ICU, neuro and medical. He really is just a wealth of knowledge, very up to date in the latest clinical guidelines and practice. So today he's going to talk to you guys about pulmonary disorders and acute neurological injury. Okay.
All right. So first of all, thank you everybody for being here and hanging out with us today. This lecture has been 2 years in the making. Dr. Naval and Christy asked me to do a talk for this conference, and then this thing called COVID happened and we haven't been able to hang out since. So definitely a pleasure to be with you all here today. As she mentioned, I'm an intensivist. So I really like taking care of the critically ill, but thankfully we have a neurocritical care team that's excellent at our facility that I could count on, because even though I am neurocritical care trained, I'd rather not do it. So, and thank you everybody who takes care of patients. Is the presentation gonna load up? All right, there we go. Let me figure out how to pass these slides. So I am gonna be discussing, so this is not the beginning of the presentation. This is in the middle, guys. All right, you're gonna have to go back a bunch of slides. Keep on cruising. I mean, I could improvise a whole entire lecture. So to start off with the disclosures, I speak for Fisher and Paykel, but one of the things I always like to disclose is the fact that everything I say is evidence-based, generally speaking. So there's citations on, hey, there we go. There's citations on all my slides. Hold on a second. But if you see a study or something that I discussed that you want to read into it more, feel free to email me. Contact me through social media or even telematic me, and I'll eventually get back to you. All right, I guess this is, are we having a hard time? It's working? Which button is it? The green one? All right, there we go. Okay. For any CME lecture, we have to put objectives. So those are the 3 objectives. We're going to look at the different neurologic injuries that cause acute pulmonary injury. Jeez. Okay, we're going to have a good time here. But first of all, let's just go with this slide. This is something that if I see today, a CT scan that looks like this, I'm going to make a phone call and be like, okay, somebody else needs to come and take care of this patient because it's been a long time and I got rust all over me. But nonetheless, the whole reason why we're here is to discuss the pulmonary manifestations that we see. And as Dr. Effendi mentioned earlier, patients who have subarachnoid hemorrhages, they tend to develop this neurogenic pulmonary edema that you're seeing here. And so there we go, 24% of patients with subarachnoid hemorrhage go ahead and develop this neurogenic pulmonary edema, but we also see it in patients with acute head injury. Thankfully, we don't take care of traumatic brain injury at our institution because those patients are, generally speaking, a mess. But we also see it in patients with status epilepticus. And I'm not going to go into all the inflammatory mechanisms, the leaking of interleukins and cytokines and such, which end up causing this. But the bottom line is that we have to support these patients while they go through their pulmonary manifestations and help them get out on the other side. So other etiologies include patients who aspirate as well as ventilator-associated pneumonias. Okay, so one of the things that causes a lot of confusion in these patients when we're taking care of them is trying to sort out whether they do have that neurogenic pulmonary edema or do they have the aspiration pneumonia. And these different characteristics help us kind of determine if it is one versus the other, but they're not 100%. For example, neurogenic pulmonary edema is said to take place within hours after insult versus aspiration pneumonia, 24 hours. But we've all seen those patients who just aspirate as soon as they hit the ED, you know, they get gorked out and such, and they're not quite protecting their airway, so they might go ahead and aspirate. There is a question of whether or not either of these have fever. Both of them have PF ratios. For those who are not familiar with PF ratios, it's the PaO2 over FiO2. It's how we categorize the severity of respiratory failure. Obviously, in both of these patient populations, it tends to be decreased. One of the things that could help us differentiate between the two is the chest X-ray. In neurogenic pulmonary edema, you see both sides of the lungs fluff out, versus in a lot of patients, you see that right lower lobe infiltrate in those who aspirate. Leukocytosis could be present in both. CRP elevation could be present in both. And then one of the things that happens quite often, and I'm going to go off on a little bit of the tangent, is procalcitonin. How many people use procalcitonin to rule in and rule out infection? Show of hands. Okay, not many people. I'm glad to hear that, because it's not good. It's not a good test to go ahead and say, hey, if the procalcitonin is negative, this is not a bacterial infection. Just in patients who have a positive procalcitonin, that does not mean that they do not have an active infection. But one of the things that could help us is the evolution, although, every patient is different at the end of the day. If it's usually between 1 to 3 days that the patient's sick, that's indicative most likely of neurogenic pulmonary edema, versus those patients who aspirate, well, they might take a little bit longer to go ahead and shake their pulmonary manifestations. Okay, so what PaO2 and what PaCO2 should we target in our patients? With regards to the PaO2, we want to try to keep it between 80 to 120 millimeters of mercury. The thing is that we like to see patients who are hypoxic. We hook them up to whatever oxygen device we have, and we just crank that baby up because we like to see the sats of 100. But we need to keep in mind that having hyperoxia is actually detrimental to a lot of our patients. Even though a lot of the clinical trials haven't really shown harm to hyperoxia necessarily, they're doing a lot of studies out of Australia and New Zealand in critically ill patients looking at this. We do know that a PaO2 of greater than 300 is not something that's favorable for our patients. Now, with regards to the PaCO2, here we kind of have to stick by the book. We want to use that normal reference range of sorts between 35 to 45 millimeters of mercury. We want to keep these patients here because hypercapnia is not something that the brain likes. Okay, in the medical ICU and the other ICUs where I work, I have the luxury of allowing my ARDS patients to have permissive hypercapnia. You all in the neurocritical care world, unfortunately, do not have that luxury. So just something to keep in mind. Okay, so we're looking at patients who have hypoxemic respiratory failure from a number of etiologies, and the question is always, who should we be intubating? A lot of these different parameters should not be a surprise to any of us, even though we kind of dance the fine line every now and then, because, for example, we all read the textbooks and the medical journals that say if your GCS is less than 8, go ahead and intubate. But, we really don't do this in the real world. Heck, sometimes we even extubate people with GCSs less than this. In addition to that, if the patient has a decreased level of consciousness, if they're severely agitated and combative, these people do get intubated because I don't want them to hit my staff. Like, that's got to protect our people. And then patients who lose their airway reflexes, you also have to tube them, as well as patients with significant ICP elevations. But what about patients with Guillain-Barré? And so this is a topic that I haven't had to think of in a long time, but I was having a discussion the other day with Dr. Shah, one of the neurocritical care doctors, and it prompted me to kind of go down the rabbit hole of how to care for these patients. And there are a number of algorithms which I don't expect you to memorize because I went through it and it didn't hold my attention span very long. But nonetheless, there is this 20, 30, 40 rule that exists in patients with Guillain-Barré, where if the patient has a forced vital capacity below 20 cc's per kilogram, these patients need ICU. If their maximum inspiratory pressure is above negative 30, or the maximum expiratory pressure is below 40 centimeters of water, these patients should be admitted to the ICU. But at the same time, some even say that these are criteria that you should use to go ahead and intubate patients. Now, intubation parameters, and again, the data is all over the place with this, if I'm being quite frank, because some are even saying that the 20, 30, 40 rule should not be applicable any longer. But I digress. I'm not going to get into that debate, really. I'll let Naval and Dr. Shah, Muradi, and Chimasani figure that out. But these are the parameters that one should use if the patient needs to be intubated. But here's the thing. We have these patients, they don't look so great, but we know what intubation is going to do to them. And of course, the patients who need to be intubated, go ahead and intubate them. But we know that some of these patients might get away with using some non-invasive ventilation or some high flow. By non-invasive ventilation, I mean using BiPAP. That's what we all colloquially call it amongst discussions with ourselves. Anybody with a mask on their face, that's BiPAP, even though BiPAP is a proprietary term. But all of these different methods that I'm showing here on this slide are all non-invasive ventilation, going from the new nasal masks that a lot of us have to the second one, which is the conventional non-invasive ventilation that we have mostly at our institution at Baptist. Some of us have the scuba mask that's listed there. And how many people have seen that helmet before? So that helmet's actually really cool. And it came to the forefront during COVID because in Italy as well in Spain, they use this a lot. And the really cool thing about this is that the clinical trials that showed that it's actually better than the other 3 masks shown previously came out of Chicago. And in patients who have ARDS, patients have decreased risk of intubation and decreased risk of mortality when they use that mask. So we may end up seeing it sooner rather than later because there are fewer complications with it. But nonetheless, some people even go ahead and say that the high flow nasal cannula systems that we have at our institution are also considered non-invasive, but I'm just going to go ahead and call it high flow for the sake of discussing it. So when you have a patient with a neurologic injury, there are honestly no formal recommendations when it comes to should we be using non-invasive ventilation. And one could kind of figure that out. I mean, what are you going to do? A patient with subarachnoid hemorrhage, you're going to say, hey, I want to enroll you into this trial where I'm going to randomize you to either get, it's just not going to work out. I don't know how many people have participated in clinical trials, but it doesn't go well. So there are no formal recommendations. So we're kind of in the gray zone, so to speak. But one of the things we could do, and this is what I'm going to focus on in this lecture, is try to apply utilizations for both non-invasive ventilation as well as high flow in a different patient population. We're just trying to extrapolate that data. So when you go ahead and look at the utilization of BiPAP, I hate calling it BiPAP, but we all speak the same language, but using it in patients with pulmonary edema, cardiogenic pulmonary edema, we find that it actually decreases hospital mortality by 35%. So if we use this rather than intubate folks, we can have a decrease in mortality with a number needed to benefit of just 17. If you use it to look at intubation rates, patients with pulmonary edema, you decrease the risk of intubating a patient by 51%. So number needed to benefit here is just 13. So I know it's not the same type of pulmonary edema, but if you could kind of hold the fort down for a little bit, it's something that could be useful. But what about the utilization of non-invasive ventilation in both ARDS as well as pneumonia? Because this is something that we take care of in the neuro ICU. Well, you all take care of, I used to. But if you extrapolate from previous data, and this was a systematic review and meta-analysis published in 2017, it decreases the risk of intubation by using the non-invasive mask by 41%. There's no difference in ICU mortality, but there is a difference in decreased risk of hospital mortality where it goes down by 54%. Just remember that even though, yes, there are some people who we have to intubate, there's a lot of stuff that goes on that could go wrong either during the intubation period with your pre-oxygenation, your RSI medications, and just the act of keeping somebody sedated. It's not going to be helpful necessarily for their recovery. So we all know that there are contraindications to non-invasive ventilation. You know, if the patient has an encephalopathy that's worsening, if they're unable to cooperate, if they're apneic, you know, you should just go ahead and intubate them. Unless you want to try AVAPS. So I'm going to discuss AVAPS a little bit. It's completely off label, but we're here for fun stuff, so I bring it. If the patient can't protect their airway, if they can't clear their secretions, they also likely need to be intubated, and airway obstruction, GI bleeds, hemodynamic instability. If somebody had facial surgery, trauma burns, an undrained pneumothorax, as well as patients who are vomiting, well, these patients just need the tube. So those are all contraindications to non-invasive ventilation. So now let's talk about AVAPS. I wrote down that it stands for average volume assured pressure support, and I directly read it off my slide because I can never remember what it stands for. I've been using it for a long time, and it always just trips me up when people are like, what does it stand for? I'm like, I don't know, just Google it. But how many of you all are familiar with AVAPS and have used it in your practice? Okay, I see one hand. Okay, yeah, awesome. Okay, so I have a couple people. So in the devices that we have at our institution, we have the V60 Respironics Philips BiPAP machine is what we call it. And this is the usual mode that we set patients on, which is the ST spontaneous time setting. And we usually set conventionally patients on an IPAP, an EPAP, we set a rate, we set an FiO2 there, and we set a particular inspiratory time, right? But if you look at the bottom, there are those different little buttons, so to speak, and one of them is modes. So when you go ahead and you select the modes button, you find that you have the option to put somebody on AVAPS. So you go ahead and you click that little button and you see that you're able to select a tidal volume for your patient. Because one of the things about putting somebody on BiPAP is that, you try to generate a certain tidal volume by increasing the IPAP. But here, instead of having a set IPAP on the particular device, you have a range. You see where it says min P and max P? That's your IPAP. You actually set the patient up on a range of pressure in order to achieve a certain tidal volume. So basically, it behaves like volume control on a ventilator. So you set the volume, the machine chooses the pressure on every breath, and like that, you're able to oxygenate and ventilate your patient better. Now, one of the things I always recommend when you set somebody on AVAPS is to just stay at the bedside and just hold on to your sphincter for a little bit, because it takes a while to work. See, the machine is actually trying to determine what the airway pressures are of the patient and how much pressure they're going to need to give the patient to actually generate said tidal volume. Okay, so I went over the owner's manual just in these past couple of days trying to figure out, like, is there something else about AVAPS I need to cover? And I ran into something pretty funny. This is not meant for you to read, but it says there, during AVAP setup, there may be a period of time before target tidal volume is achieved. So I found that quite redeeming, that I was like, okay, it just doesn't happen to me. It happens to everybody, that it's on the manufacturer's listing. But one of the things is I use AVAPS a lot in the patients who have obstructive sleep apnea, who, they call me at the bedside because they're obtunded for whatever reason. They have a pH of 6.8 or 6.9. And I don't want to quite intubate them because all they need is a little bit of Narcan and a little bit of time. I just put them on AVAPS, jack up the tidal volumes, and give it time for it to work. It's not 100%, but it's something that you all could use in your practice potentially to help you both oxygenate and ventilate your patient. But what about high flow? So high flow also has no data. Nobody's surprised. Same parameters. You can't enroll these patients in a trial. But we could infer certain indications for the high flow nasal cannula device that we all have at our institution. Looking at just the mechanism of action of it, looking at the device, we have the flow meter, it has an air oxygen blender, and it also has a heated and humidified inspiratory circuit. And then it all comes onto a nasal cannula, which is a nicer interface because our patients could talk to us, they could eat, they could FaceTime, et cetera, et cetera. But one of the things that's very important, and sometimes it's something that's missed, is how important the flow meter actually is. Okay, the reason why I say this is because right now, when we take breaths, we're taking about 35 liters of flow, just normal breaths. I'm breathing a little bit faster, but that's because I'm running my mouth. But what happens is that if you put somebody on 4 liters nasal cannula, they're getting those 4 liters at 100% FiO2. But what happens? The rest of the breath that we're getting in is being entrained with room air. So even though we're thinking we're giving patients a lot of oxygen, we're really not doing so. And that's elaborated here in this particular slide. You see that you're just giving 4 liters. The rest of the 35 is just entrainment of ambient air. It's not that good for oxygenation. But if you go ahead and you put somebody on 35 liters of flow on the high flow nasal cannula system, you actually are giving them 100% oxygen because they're not actually entraining any ambient air or whatever oxygen concentration you set on your little knob. But this ends up being beneficial for a number of reasons. This also increases the patient's airway pressure. And so you all have heard, and I'm going to show you the data for this, but you all have probably heard that the high flow nasal cannula system actually creates PEEP. It actually creates CPAP or IPAP, or EPAP, these particular terms. And the reason why this has been proven before is because they've actually done studies where they've looked at the end expiratory lung volumes on patients. They found that just using high flow helps recruit lungs and could also help increase lung compliance. All these things help to improve oxygenation in your patients. So maybe you could get away with not intubating them. You could also crank up the FiO2, and this will also help out your PaO2 for these patients. And as you improve the lung compliance of these folks, it ends up decreasing the patient's respiratory drive. They become less tachypnic. They just start looking better. But you do have to crank up the flows on these patients, and some, especially those who have ARDS, in order to see a response. It also helps to wash out the dead space in these patients. It helps decrease the PaCO2. And what does this do? This decreases the work of breathing of the patients and also decreases their respiratory effort. So they even look a little bit more comfortable. One of the other things is that the high flow systems also provide the patients with a significant amount of humidity. One of the things that happens in neurocritical care patients is that they have all these secretions that dry out and then they can't quite get it up. Well, the humidity helps keep the cilia within the lungs happy. So those little cilia start bringing up all the sputum, and hopefully you all could suction them out, but hopefully better than that, the patient could cough them up themselves. So different beneficial factors there. All this helps out the patient's comfort. So talked about all these different things, and there are different slides, and I'm not going to go over this, but if you're really nerdy about all these mechanisms of action, I could get you this slide. Okay, but whatever you want to do on Friday night. One of the things that I do want to elaborate on is that this is the interface that we have at our particular institution with the high flow. There tends to be a practice where everybody's put on 31 degrees Celsius on these devices. Just know that for the sake of clearing mucus and helping the patients breathe better, we got to start cranking that up to 34 degrees or even 37 degrees. It's challenging because, you know, the RTs go ahead and they set it up at 31 because then they say that the patients say that it feels too warm. But if you just have some communication with the patient, say, hey, this is going to help you get better. That's something that you could potentially do to help your patient outcomes. Okay. So discussing about how the high flow generates PEEP. These are these studies that were actually performed in the CVICU. And they found that for approximately every 10 liters of flow that we crank up, they get about 1 more centimeter of water of PEEP. Okay, a number of studies have shown that. But what about patients who are mouth breathers, right? We all have that question. And here they've actually found that even though there is a decrease in the amount of PEEP that the patient does receive, they still are receiving some airway pressure that gets down to the lungs, helps recruit alveoli, and hopefully helps improve outcome. But how could we extrapolate all these different mechanisms of action that, you know, sound nice and theoretical? How could we extrapolate this to our patients with ARDS? And this is where we use a medical ICU trial called the Florali trial, published in 2015 in the New England Journal of Medicine, to our potential aspiration pneumonia, and maybe even neurogenic pulmonary edema in certain patient populations. And so what they did here is that they randomized patients who had pneumonia or aspiration pneumonia, anything that created ARDS. They randomized them to either be on high flow nasal cannula, non-invasive ventilation, or conventional oxygen therapy. By conventional oxygen therapy, people on non-rebreathers or venti masks, for example, right? And so many people ask, hey, when we start somebody on high flow, what settings should we set them on? And 50 liters, 100% is what they did in this trial. But when they put people on non-invasive ventilation, they put them on 7 to 10 cc's per kilogram of ideal body weight. Now, for those of us who are familiar with taking care of ARDS patients, we're already like our radars are going off saying, hey, that's way too high, right? We try to aim for 4 to 6 cc's per kilogram of ideal body weight. So that might be a limitation to this trial. And then patients who are on, for example, non-rebreather, 10 liters of flow, 100% FiO2. And so their primary outcome was intubation rates, right? And between the three, there's no difference. So you're probably saying to me, hey, my emoji didn't come out right, but it's the this is emoji. Like, so why are you telling us about this trial if there's no difference, right? But the reality is that when they did a subgroup analysis, they looked at the patients who were sicker, those patients who had a PF ratio of less than 200. And what did they find? Well, it found that fewer people who were on high flow actually passed away, with a number needed to treat to save a life of just 7.6 compared to somebody being on BiPAP. Then 90-day mortality was also better in the patients who used high flow. And all in all, they were able to keep more patients off of mechanical ventilation by using high flow versus the other devices, which are all pretty good things for our patients, right? I like Kaplan-Meier curves because the colors are pretty. But you could clearly see how the high flow patients did better with regards to the incidence of intubation. But if you look at the trend for non-invasive ventilation, you actually see that the rates of intubation were higher than those on conventional oxygen therapy. Why is that? Well, they were trashing the people's lungs by giving them 7 to 10 cc's per kilogram of ideal body weight. The takeaway I like to say about that particular finding is that whenever you all have a patient who's on non-invasive ventilation, and you're looking at the screen and you're seeing that they're taking tidal volumes of like 700 or 800, you need to get that under control or just intubate them. The reason why is because you're causing volutrauma, barotrauma, and you're just worsening their outcomes over the long term. You know, those people just need to go ahead and be intubated. So the guidelines have now said for patients with hypoxemic respiratory failure, go ahead and use high flow over the other two devices. The surviving sepsis guidelines also say the same thing. Even though it's a weak recommendation with low quality of evidence, they still say use high flow over the other two. There's even data for using high flow in pulmonary edema for the mechanisms mentioned earlier. It decreases patients' respiratory rate and decreases their work of breathing. So you could potentially use this. Obviously, somebody who is completely whited out, like that first chest x-ray, yeah, that person's not gonna fly on high flow, right? We have to be honest. But it's something that you could keep in your back pocket, may be beneficial to the patient. But one of the things we can't forget to do is actually prone our patients who are on high flow, okay? And this goes back to medical ICU studies, such as the Prosivo study. But we've actually looked at this, and this particular paper is from 2013, so almost 10 years old now, where using a particular technology called electrical impedance tomography. If you look at the left side, that's a patient who's laying down on their back, they're supine, and you can see that the distribution of the gas is not very homogeneous. However, they went ahead and prone the same person, and you see a more homogeneous distribution of the gases. And for non-infectious ARDS, we are seeing benefits, and this was a particular trial that was published in March of 2020, right before you know what, where they were showing how this could be beneficial in patients with non-infectious ARDS. And since then, meta-analyses and systematic reviews have taken place where it shows that proning your patients, obviously don't prone certain patients with elevated ICPs and all that, you know, use good clinical judgment there, but it does help oxygenation. There's no clear intubation benefit. However, there is a trend towards it being better. Obviously, trends don't mean anything for those of us who are statistical purists, but there is a mortality benefit when you do prone your patients on high flow nasal cannula. But it's even better in patients who are prone for more than 4 hours per day. So just keep that in mind, as it could be a tool for your tool belt. So should we prone patients? When I looked for the data, there was no data, as one could imagine, but some of the neurology journals say that it could be considered in patients who do not have a significant elevation of their ICP. We could also use high flow in patients post-extubation, you know, those questionable extubations that we do all the time. If somebody is low risk, they've done studies where they've randomized them to be either on conventional oxygen therapy versus high flow. And what they found is that you could avoid intubations by putting people on high flow, okay? However, the more dicey extubations that we all do, you know, sometimes we think about, hey, let's just extubate them and put them on BiPAP, right? But they've actually done studies looking at BiPAP versus high flow in these high-risk patients that we take care of every day. And what they found is that there's no difference between the two groups. No difference in all-cause reintubation, no difference in post-extubation respiratory failures, but they did find that patients on BiPAP have more complications than the high flow. So there's a conditional recommendation to use high flow over non-invasive ventilation post-extubation, just something to keep in mind. And I know what a lot of you are thinking. This is a lot of medical ICU data, and this is a lot of cardiothoracic and cardiac ICU data, but is there no data in the neuro world? And we've all seen these pictures of this particular patient who's undergoing a craniotomy for a resection of a brain mass, and she's playing the violin while wearing the high flow nasal cannula. So this is about the extent of where the data is. And it's true, you go on PubMed and you try to look this stuff up and you hear crickets, like PubMed's like, anyway, so they do have fewer airway obstructions, fewer injuries, and the patients are able to maintain a longer awake time when using the high flow system. So to wrap this up, as I have 1 minute and 52 seconds left, I did it. With regards to your target of PaO2, you want to shoot between 80 to $120. PaCO2, try to keep it in the sweet spot between 35 to 45. Obviously, if the patient needs to be intubated, just go ahead and tube them, okay? All the data shows that if you really, really delay intubation on patients, the mortality numbers just shoot up. But with our clinical judgment, we could possibly tease out who's gonna have better outcomes without needing to be intubated. You could try non-invasive ventilation as well as high flow in select patients. And ultimately, AVAPS is fun and easy. I definitely recommend you try it out. It always gets very dicey when you actually set the patient up, waiting for them to actually take a good, strong tidal volume. So at this point, I'd like to invite any questions, comments, concerns, complaints, all those things. All right, I think we're good here. Cool, good talk.
I have the mic.